as a different opinion. I mean, of course, Bishal is not opposed to BIM pros, but coming from the developing markets perspective. Bishal, thank you very much. Turning the camera on. As founder and CEO of Health at Home, I'm sure that you will give your perspective on developing markets and healthcare. And thanks for being with us today. It's good to see you too.
Thank you, Khan. It's always a pleasure to be in your company and Hackquarters and Health at Home. Can you hear me?
I think, yes, we can.
Yeah, thank you.
Always great to see you. I mean, and now I just turned off my presentation. So whenever you want to start, feel free to share it, and I will slowly and silently leave the stage to you. Good luck.
Thank you. Good evening, and Khan, it's always nice to be in company of Hackquarters and all the friends of Hackquarters. I'm very pleased to be back in a program, and I'm very happy also to see Sardar, who was maybe a couple of years back. He was startup invested by Bayer in acceleration program, and I got to work with him on a voice-enabled healthcare app. So seeing and sharing this program with him is such a pride, and I'm really proud about the achievement that Albert has done in these years. With saying that, I mean, today we are here to talk about digital healthcare and evolution, and I bring in the perspective of Nepal. First of all, probably the perspective of Nepal is itself a complex understanding, because West Europe has its own standards of thinking and working, and healthcare is also one of it. And to bring that perspective, probably I need to tell a little bit about my country. Nepal is a mountainous landlocked country in South Asia. It has two big countries like India and China, which is in its north-south. In India sits in north, south side, east and west. And then we have very mountainous, rugged terrain. It's very difficult terrain to navigate. So why it's important, because the access of Nepal's healthcare is very complex. So, we spend a couple of days traveling for accessing healthcare. I have great friends in audience today who actually has joined in from around the world. And also they have been talking about all these things also around the world. So we have these problems of multiple issues like access, and then we have infrastructure issues, we have machinery issues, we have transportation issues. So all these things are something peripheral in healthcare. Apart from Dr. Christian's amazing presentation, I think I want to connect dot on that later on, that FIMPRO actually sounds very close to my heart, by it interconnects all these things. But then we also have a 70% out-of-pocket payment model, where our people who are poor actually have to pay, not from the insurance, not from the government welfare, but out from the pocket. So our model is very unique. And that's actually talks about a lot of other countries also, which has a problem like that. So saying that, we have come across two waves of COVID crisis. We have around 9,000 deaths. We have around, let's say, 650,000 positive cases. So it's pretty significantly large number that we have. And then we have a problem with our vaccination, and we have problem with our medication and hospital availability, all these things. So that's the current scenario coming out from Nepal. We have in digital side, if I have to introduce what kind of situation we have a very interesting situation and skewness in public health and then digital access. So we have around cellular penetration is around 42.85% population has access. Our population is around 30 million. We have internet penetration of about 10 million people. We have social media penetration of 99%, and we have cellular penetration of around 150%. So, but our sanitation toilet access is around 70%. So there's a huge gap in digital access and public health infrastructures, even in a personal people's life. Having said that, there's a lot of good things also. In COVID, we have seen a lot of skewness in care management, access, and quality of care has been a problem also. But in public health scorecard, I think like I have a couple of data to share before I start. Like tuberculosis treatment cure capacity is around 65%, whereas our efficiency on taking care of COVID is around, at least 90%, I would say. So antiretroviral therapy also goes the same. Having said that, digital evolution is pretty much strong, and that actually can be a defining moment for Nepali people to have an access to healthcare. And access is very complicated for Nepali because the terrain is complicated. So telemedicine or digital healthcare or access to healthcare through a digital platform is organic positioning for our next level of healthcare. With COVID, it just became organic. So going to my presentation, that's my introduction to the situation that I live in. I live in Kathmandu, and it's a beautiful place. Regarding healthcare situation, it's pretty standard urban setup we have. Regarding connectivity and community care, that's what two part that actually connects and creates a digital healthcare. Is in community care, you find a lot of pre-hospital services. You find a lot of hospital. That goes with any country in the world, and post-hospital services, home health care, patient transfers, and workspaces. These are all the spaces where the population actually live and actually might need healthcare. And there's a connectivity, which is like from telephony. That's where we started. Then we have mobile technology, internet-enabled apps, wearable sensors, portable diagnostic devices. Why I'm saying so, and why I'm basic, because to connect to the Vimpro that Dr. Christian said, absolutely makes sense. If you really want to understand how healthcare has been evolving around the world, it's an organic need that we have. So in healthcare systems, largely we have we had three models which were existent before health at home was conceived. I mean, I can tell about Nepal and South Asia. There was no model called home healthcare or integrated healthcare that I can be 100% sure to share with you. With regarding other countries, I think there were patches of those kind of services, but they were not own 100% as a model of integrated care where you can pick up a phone and get a Vimpro kind of model. So when I started, it was like kind of thought about it, like it will solve that whole gap on access away from hospital. So when you think about healthcare system, I have divided, and then that's standard practice also. It's individual practitioners themselves are an institution, they can run a clinic, things like that. Group practices where there is few people of a different specialties come together and serve the community. Then there's the large infrastructure practices like hospitals where they have CAT scan, MRI, laboratory with good setup, ICUs, emergencies, transport services, everything that is heavy. It's like a big elephant sitting in there. And then there's like a home healthcare, which is fourth vertical item. And this is absolutely true that the home can be a largest portion of a healthcare services delivery platform ever we have in societies. Then we have a digital healthcare, which is actually faster progression as an independent vertical on a healthcare system. So how does it shape around digital healthcare and home healthcare has not been that much evolved around the world. So how to integrate that it's my pursuit of my life, and that's what I'm working on. So here it comes. In 2009, I was a resident in cardiac surgery in Lahore. I started thinking about going out of hospital environment. It just became too strong, and then I just decided to quit that and came back home, and I started that. So 2010, 2021, 11, 12 years now, we are here, working on the same model. Healthcare needs to come out of hospital, that's for sure. 80% of the current hospital system, healthcare system, can be services which are there in the hospital, like outpatient services, which has repeat visits, follow-ups, consultations, which can be a primary care model, long-term cares, rehabilitation services, so many things, and palliative and end of life. All these care models can come back to home and can be managed properly, and probably augment with technology will make it much more affordable, more ethical and evidence-based, managed by a Vimpro-like model. And then we have why in COVID we had sudden interest in all those areas. I mean, it's my space. I think like, I'm very much possessive about it. And then I do talk about it. It's because of the nature of disease, the contagiousness and the public health interest. I mean, we have internal air quality issues. We have a lot of crises around protective gear. We have all this adaptation around infection prevention and control has become mainstream. So when it came, then we all had to shut down to our home, and actually we had to isolate and get connected to some kind of services. So that actually unleashed that whole Pandora box of that untalked about but then there was technology to rescue. There's like a whole rescue that came in was mobile phones, those telephones. You can call up a doctor. The hospital systems were packed. You can't get into the hospital because of the logistic problems, or unknown issues were there because the families were fearful, or person itself were not very convinced. So clinical decision making, support, counseling, all these things came in play very strongly across the world. So there was like huge burst of growth around the world, like around, I think I see 500% growth on Kagar, which actually is a huge number. Even if you leave the outliers and then dropouts, we still have 100% growth year on year across those verticals and technology served healthcare models. So there's a huge scope, and then there's a lot of potential around those ideas. So that's why they've adopted faster. It has a huge benefit on telephone triaging, navigation, care support, counseling, treatment management. All these things are there in place. So we have issues also, or we have patients not adapting to it. There's like patients' rigidity on their understanding of the leverages they get because they will be connected to a physician who's credible and has the capacity to sell. Behavioral change has been an issue, resistance in use of digital technologies, digital divide, which is big in the developing world, is very, very big. And still we have around a huge gap on a digital divide. If I talk about only Nepal, probably of a cluster of a population that we live in, it's not very comfortable to actually talk about the poverty-driven areas or the people with a lesser access to technology and services. So it will still be there, which is a big issue for access to patient for everyone. But it makes a lot of sense because it's still one of the frugal models that we can think about. Providers, it's a quality metrics we don't have. We have ethical issues on prescriptions and all. We have policy gap. We have monetization issues, incentives that physicians or the practitioners should look into. And there's a payer market issues, like we don't have a standard payer market like Nepal or other developing world, which is big number. 50 are the West, and even Turkey would fall in that category. But 250 countries doesn't have those things, those luxuries of a payer market, standardization, insurance structures, hospital systems which accepts those kind of payer solutions. Universal healthcare even is a huge gap in the world. So policy gaps are there. Insurance welfare coverage is a gap. So no commercial models are available, at least on a market availability is also another. So there's a gap even in innovation and platforms that can offer. So it was a huge benefit for us, like a health at home was there, ready to adapt to it. So we had hospitals, they don't know what to do. But we were ready for it because we might not have a technology, but we started developing our technology. So looking at the COVID and that interface, which we are using now, for the long, long time. And that was the vision. We wanted to connect the digital divide. And if you see that whole metamorphosis around personalized healthcare, there's a lot of example. I mean, everyone is aware about it. But there's like a simple example of EKG machine where the galvanometer that the scientist is sitting with is a huge machine. It's almost like a car. And then there comes a middle age, EKG, which is still like a suitcase. And then there goes a life core cardia, which is like a cell phone augmented, just slap it in the back and use it. It might not work all the way 100%. It is too, this is specific about it. It's very close to giving us what impression it gives with the galvanometer. So everything is becoming portable. It's very close to the home. It's coming close to our pockets. So it's very easy for us to use anywhere we go. So that's how the technology, that connectivity and people requirement are all coming together to fuse with each other and actually shortening the access divide and making quality healthcare possible for a lot of people. And there you go. So what happened with COVID was Health at Home 2.0 had to work. So what we had for 10 years, we had 7 services augmented over the telephone. We would get a call. I need a doctor. I need a nurse. I need carer. I need physio. I need lab. I need pharmacy, or I need transport. I need appointments. Those were the model that when we say it's telephone, it's a digital, it's not digital, it's technology driven. But when it come to COVID, we needed to adopt, because the 50% of the services that we did were either risk items, like placing nurses for the people, going to the visit of by a doctor to a patient, either they're symptomatic or they might be carrying to the people who are vulnerable category. So all these things made our 50% of the service line redundant. It doesn't work. So we had to check it out. Then we had to adapt to the 50% of the newer things like Viber, WhatsApp, or build our own technology fast so that we can bring it together. And actually, by compulsion or the situation, we were supposed to deliver it to the people. So we brought in a new version of Health at Home, which is integrated with the requirement of the people. They were in home. And then our experience with the past, we brought it together and we delivered. So that's a hybrid healthcare model that I call it. We need to talk to them. We need to counsel. We need to prescribe, but we also need to go and do our blood. We need to do PCRs. We need to go and do a consultation if there's some kind of signs and symptoms. So all these things we're doing on the physical side and then digital side. So it became a kind of a hybrid. And it is a hybrid. It is intermediate model before we actually catapult into the absolute digital model for individuals. So this is something that has come out. And I think there's a lot of experience on that around the world. And this is a timeline. We were born in 2010. We went for 10-11. We went for one-stop service. That's what I talked about. Then we had 2012. We have National Social Enterprise Award. Then we have 2014 United States State Department Award. We went on 16, started developing technology, thinking technology is going to be a big thing for every individual to have access to doctors. We already started developing technology. I think Khan and Sabina actually are aware about my pitches and talk all the way every time we meet. And then I always believe in this hybrid model. For now, at least in my generation, this is going to stay here for a while. And these are the impact that we created during COVID. What we did with our hybrid understanding, we were very open. We actually started talking to people around the country with the help of Ncell, that's our cellular company. We did around 50,000 teletrials with help of 20-25 people, where the people can just pick up the phone and talk to us. So asking about, so those are the first wave, that's like 2020, January, February, March time. So we started picking it up with just telephone distributed in a VIP network. So we got that telephone trials done, that's digital. Then we went on to supporting them on online remote patient monitoring, home isolation services. So we do, once they test positive, once they're curious, they come to teletrials. Once they're positive, they get into the home isolation program. So we do home isolation program. We have experience with dealing with public-private partnership models, and then we have a private enterprise model and independent clients. So we have like around 5,000 plus cases handled. We have remote patient monitoring solutions and services using applications and over freewares and all. So we also use online service booking now. We have an end-to-end booking model. We have run requests on that. We have OTC pharmacy deliveries. We have oxygen support and rental services through that technologies. And then we had labs like PCRs and blood tests. So all these things combined, this is what we did around COVID, which was a big impact. And actually we were at parallel with a lot of initiatives with government or had served together with them, at least in ideation level or serving the community together. That's on the COVID side. And then there's like all these services that we have done, like app booking, onboarding, in-person clinical consultation, lab workups, prescription pharmacies, remote monitoring, rehabilitation long-term. We do post-COVID consultations and psychological things. We support them on a respiratory therapies and rehabilitation program. We assess them remotely. We have pre-COVID, COVID, post-COVID services. We have 3 COVID services. patient navigation and remote management. Those are all things digitally done. And I think with 2.0, we are not going to stop. We're moving towards a different kind of a zone, but not right away, because those personalized devices, like the Cardia that you saw with EKG, and then digital enhancement with WIMPRO, and rise of the institutions like Health at Home, it says only one thing, that there will be a individualized healthcare service models, completely digital, that will be independent of the existing structures or whatever the infrastructures will be there. That is independent of my choice, that I'm going to use a wellness tool. I'm going to use my diagnostic services, diagnostic solution, completely churned out in a digital environment on AI, ML, or wearable technologies or sensors enabled, which will churn out 80% of the services. There's a famous quote from Vinod Khosla, an entrepreneur in Silicon Valley. So he teasingly, actually, to all the medical practitioners, said 80% of the services will be done digitally, which I think is right, but it will come around next 10 years at least. But then there's institutionalized digital mess that will happen. That is also empowering people, connecting that APIs and things with the individualized healthcare, with hospital mess, and then home healthcare mess, and then there's other kind of mess. So these are institutional mess that what we have, like polyclinics will become digital and physical. And then there is like, I think the hospital systems will have their own digital mess, which they will have a patient record, connected services, telemedicine, all these things. So all these things will be institutionalized, will be individualized. And that's how healthcare seems to be moving forward in digital. This is my understanding, coming from a difficult part of the world, but with a very, very exciting opportunities. And I think we're gonna grow another, at least for a few years, 100% at least minimum. And there are a lot of companies like us around the world which is looking at these areas and coming up very fast. In the last 1.5 years, we have seen at least 50 to 100 companies which have sprung, at least digital pharmacies, those digital teleconsultation services, hospital adapting to new kind of services and solutions. So there's a lot of scope that has come up. So I think there's a lot of opportunity around those areas, and I think it's a great conversation that has been started by Hackquarters. On that note, I'll stop my presentation and I'll expect some questions from you guys. Thank you very much.
Thank you, Bishal. It's always great to see you. And I hate myself when health tech startups actually talk about traction, because we generally talk about like not really nice things like clients, introductions, panels, users, and you end up saying like, we gave 500 people oxygen tanks. We did 50,000 triage in hospitals. So, it makes me feel really trivial in life, because basically what we are doing is nothing in compared to healthcare. There are some comments on the chat, by the way. And I want to add like final word. Like, I loved what Dr. Christensen also shared, and I definitely believe that there is a American way of innovation. There's also like West European way of innovation, but still everybody thinks about like developing world is the key now, and this is how it will be shaped for our future. Because as you mentioned, there are so many inequalities in terms of reaching out healthcare. There are a lot of people who are not included in our systems, and be it in Southeast Asia, be it in Africa, there are so many different cases, and the numbers of people are immense. So we cannot not hear about it. And now I'm really happy that you also met. It's too late over there, and I'm really grateful that you joined us. And sorry for that, taking this event a little bit late. So I'm glad to be your friend, and hopefully we will be in Kathmandu in some time, like if we can travel back as business as usual. So thank you very much for everything.
Thanks,
for the
presentation. And let me end up in this. My son, who was around 13 years, is actually watching this from home. I'm in office. So it's a great pleasure to introduce all of you guys, and thank you very much. And I'll stop here. There was one note that I got it from my friend, and I missed to say, as it's home healthcare needs this international standardization. I think we don't have that network and a connection around the world. I think I missed that point. And I think we do need to create and safeguard that standardization process, which is going to be the largest network on the healthcare service provision. So there has to be a framework where we have to work both on the digital side and in the home healthcare side. So I think that's a great point that I missed, and I'm ready to take questions if there are any. Thanks. I'm going to stop it.
Let me just check the chat. Then Uttam said great things about you. Thank you, Uttam. And also Vankata. Everybody loves you, Bishal. That's why we always have your audience. I mean,
you know, when you go to football stadium, you got to have your own fan club, right? So
true.
True. Yeah, he's a great friend from. Actually, he's a great friend from Finland. He runs a frugal innovation global network. He sits in Finland, and he's a great friend and supporter of what we do in a very difficult place with less resources, with a lot of passion. So great friend there. I mean, cheers to Finnish friends. Sardar, as always, I love him. Krishn's there. Yeah. Thanks, man. Thanks, guys. Thanks. Yeah.
Thank you for your time.
Absolutely. Thanks, Khan. I'm gonna leave. Yeah.
Thank you.
No.
Thank you, Shan. So then maybe we can move on to our final session of today.
Yeah. Thanks.
So, see you.